practice. So I'm particularly happy to welcome authors of both papers. We will start with the first one that was published in PLOS ONE called Feasibility of Fast CMR Strain Imaging in Patients Presenting with Acute Chest Pain. Now, strain imaging has been around for a while, especially in the echo world, but it had not taken off everywhere. And part of the problem was that there were several strain markers, some of them more or less variable. Then there was an issue with what are normal values, and so it was not. And in MR, it was also not much different. Strain imaging was considered a little bit challenging because of the relatively high temporal resolution you would need. So echo actually paved the way with speckle tracking initially. Then other tools came, such as tissue tracking and feature tracking, that both were then offered in the CMR. And the CMR evidence now is actually pretty good that strain seems to work. Now we have to find out currently where would strain imaging be particularly helpful. I think strain imaging may help us getting rid of the ejection, or our reliance on the ejection fraction as basically the marker for all things global dysfunction. I think strain, if it can be done, can provide more and often guide therapy in a better way. So with that introduction, I want to hand it over to Deborah Siri from the Heidelberg University, and also welcome Johannes Riffel, who is the first author of the paper, to report on their findings. Deborah, take it from here.
Oh, I'm sorry, I hope you can see my screen.
Yeah, we can see your screen, all good.
Okay, thank you for the introduction. It's an honor to be able to present our paper here. So it's on the feasibility of fast cardiovascular magnetic resonance strain imaging, or short F.nchez, in patients presenting with acute chest pain. F.nchez is a relatively new CMR technique which allows for the very fast assessment of myocardial strain. Strain is the fractional change in myocardial length of the myocardial fibrils between end systole and end diastole, and has already been tested in patients with coronary artery disease. However, it has not yet been assessed in patients in an acute setting, so that's what we aim to do. And we hypothesized that F.nchez CMR can accurately identify obstructive coronary artery disease, which we defined as a stenosis above 70% in patients presenting with acute chest pain. So of course, one of the main inclusion criteria was acute chest pain, and then also an initial troponin T between 5 and 52. According to the 0-1 hour algorithm, these are patients who then have an inconclusive initial troponin T and require a second troponin measurement after 1 hour, and that left us with a 1 hour time frame to perform the F.nchez CMR. Among the exclusion criteria, we had systolic heart failure and also history of coronary artery disease, both of which may have led to pre-existing myocardial scar. For the CMR protocol, we then acquired standard SSFP images for image planning, as well as T1 and T2 mapping, and then the F.nchez acquisitions. And for analysis, I'll just show you some of the raw F.nchez images. That's how they look like. We had to manually contour the images in end systole. We had 3 long axes and 3 short axes. And then the program semi-automatically calculated the regional and global strain data and presented them in bullseye plots. So blue represented normal myocardial contractility. Green was a slightly reduced myocardial contractility with a strain above -17, and then yellow were the dysfunctional segments with a strain above -10. According to these bullseye plots, we then performed a visual analysis and tried to triage the patients into 3 different groups according to the underlying cause. So if patients had a completely normal bullseye plot with normal myocardial contractility, we suspected a non-cardiac cause of the acute chest pain. Then if patients showed a globally impaired myocardial deformation, we suspected an underlying cardiac disease, but of a non-obstructive nature, such as cardiomyopathies. And then we had patients with changes in regional areas, which could also be part of coronary artery territories. Therefore, we suspected an obstructive coronary artery disease. Our mean total study time was around 38 minutes. That included patient preparation, scan time of around 14 minutes, and post-processing and analysis, which took around 10 minutes. So in total, patients were absent from the ED for around 23 minutes. We enrolled 108 patients. I'm just going to scroll down to the patient characteristics. So we had a mean age of 57 years. We recruited patients with a low to intermediate pretest probability according to the heart score. The ejection fraction was around 65.4%. And then several patients received further diagnostic procedures such as coronary angiography, stress ECG, and echocardiography to arrive at the final clinical diagnosis based on the routine diagnostic workup in the ED. And this served as our standard of reference. So we visually triaged the patients according to the bullseye plots and then compared these to the patient's final clinical diagnosis. According to the routine diagnostic workup in the ED, 85 patients were finally diagnosed with a non-cardiac form of chest pain, 17 patients had obstructive coronary artery disease, and 6 patients were diagnosed with an underlying cardiac disease such as hypertrophic cardiomyopathy or myocarditis. Based on our visual assessment of the F-sync bullseye plots, we were able to identify 14 of the patients who were suffering from obstructive coronary artery disease. Therefore, we had 3 false negative reports. We also had 12 false positive reports. And so that left us with a sensitivity of 82.4%, as well as a specificity of 86.8%, a relatively low positive predictive value with 53.8%, but a high negative predictive value of 96.3%, and therefore an overall diagnostic accuracy of 86.1%. We also took a closer look at quantifiable markers, such as the global circumferential and longitudinal strain, and we plotted these in area under the curves for the identification of obstructive coronary artery disease, together with other parameters such as ejection fraction, the ECG, and then the HSCT-NT kinetics. And as you can see, all these standard parameters had rather low area under the curves. Even the segmental analysis based on the number of segments with a strain above -17 and then the number of segments with a strain above -10 significantly improved the area under the curve. It was, however, the GCS and the GLS which outperformed all other parameters for identification of obstructive coronary artery disease. Therefore, when we looked at the logistic regression analysis, we added the GCS and GLS values to a routine diagnostic workup based on ECG, HSCT-NT kinetics, and ejection fraction, and this proved to be beneficial. Therefore, we think that using these quantifiable markers of GCS and GLS could help to arrive at a quicker diagnosis of obstructive coronary artery disease in a shorter period of time. When we looked at GLS and GCS divided by the patient's final diagnosis as if 3 different causes, you can see that it was the GLS which further allowed to differentiate between obstructive coronary artery disease and then the other underlying cardiac diseases, which of course had a larger area of impaired myocardial strain and therefore higher values than a regional change. This was, however, not possible with GCS. And when we looked at the segmental analysis, it was the number of segments with a slightly reduced myocardial strain, a strain above -17, which allowed for a differentiation between all 3 patient groups. We also looked at the mapping values. However, global and regional T1 and T2 values did not allow for differentiation between all 3 patient groups. Therefore, we performed a subgroup analysis and took a closer look at the 17 patients who were diagnosed with obstructive coronary artery disease. And we specifically looked at the affected coronary artery territories and could see that the regional circumferential strain in these areas correlated significantly with the regional T2 values. Now I'll go through the discussion and highlight some of the major findings of our study. First of all, we think that with the visual analysis of the F-sync bullseye plots, we achieved a diagnostic accuracy above 80%. So therefore, it is relatively safe to triage patients based on our findings. And it's a relatively user-independent method and a very rapid technique, and allows for identification of obstructive coronary artery disease without having to administer any form of medication or contrast agent, as well as, of course, there's no radiation involved. The negative predictive value was relatively high. Therefore, we think that a negative F-sync CMR result together with negative ECG and laboratory testing could in fact allow for a quicker and safe discharge of certain patients, and then render additional diagnostic procedures such as coronary angiography, which is an invasive technique, unnecessary. We know that the positive predictive value was relatively low. However, we think that this might be due to the relatively small sample size and also the rather small amount of patients who had confirmed obstructive coronary artery disease. when we looked at the quantifiable markers, such as GCS and GLS, both of them seem to detect myocardial injury relatively well, and also to identify obstructive coronary artery disease according to the area under the curves. And when added to routine diagnostic workup during logistic regression analysis, they proved to be beneficial. However, it is the GLS which was the most susceptible parameter to differentiate between all 3 patient diagnoses. Same goes for the number of segments with strain values above -17, and also allowed to differentiate between all 3 patient groups. However, it was the global strain which was the overall better marker for identification of obstructive coronary artery disease, when you remember the area under the curves. Therefore, we think the global strain may be a better early marker to identify obstructive coronary artery disease, and the number of affected segments might only increase later on. And another interesting finding was that with our S.nchez bullseye plots, we identified 14 patients with a globally impaired myocardial deformation, and therefore suspected an underlying cardiac disease. However, only 6 of these patients were diagnosed with an underlying cardiac disease. We then took a closer look at the other 8 patients. We looked at the SSFP images and the myocardial contractility, as well as the septal wall thickness. And in all of these 8 patients, we saw signs of hypertrophy and dilatation. So therefore, we think that, in fact, with S.nchez CMR, we may be able to identify underlying cardiac pathologies even earlier. And these might have been patients who were missed during the routine diagnostic workup based on ECG and laboratory testing only. For mapping, we found the significant correlation between regional circumferential strain and regional T2 values within the affected coronary artery territories in the subgroup analysis of patients who were suffering from obstructive coronary artery disease. And the interesting thing is that maybe with these T2 values, we might be detecting early subendocardial edema. And together with the circumferential strain, this might help to differentiate a novel onset of ischemia from pre-existing myocardial scar. However, this has to be addressed in future studies, as we excluded patients with history of coronary artery disease. I've already mentioned some of the limitations, such as the small sample size, and we also had a rather small size of patients who had obstructive coronary artery disease. We also excluded all patients with history of coronary artery disease and therefore pre-existing myocardial scar, which would be interesting to perform a study on. The pretest probability was low to intermediate, therefore only a small number of patients received further diagnostic testing, including invasive coronary imaging, and that would have been interesting to see in all patients. And additionally, we did not apply a form of stress testing. However, I have some information on that. We did perform a second study together with S.nchez and a hyperventilation breathing maneuver as a stress test. You will hear about that in the next talk. And we had some interesting results, and we aim to publish these as well. So thank you for your attention, and I'm open for questions.
Thank you very much for the very clear presentation, Deborah. So for everybody, if you have a question, please just put it in the chat window, or just unmute yourself and speak up, please. So one question that probably is in the mind of many people, Deborah, you did a lot of the evaluation. How difficult is it to actually perform the evaluation? What do you actually have to do for that?
In fact, it's a very simple method. It's easy to learn. So you have to click through the images, find the ancestry, and then just contour the images like in this picture here. That's in fact everything you need to do. So it's 3 long axis, 3 short axis is enough.
Mm-hmm. Yeah. Okay, and it's manual contouring, so you have to draw that there. Okay, and we'll talk maybe a little bit later about the acquisition with Marco's talk. But from your point of view, so you mentioned both the circumferential and the longitudinal strain, and your conclusion was that it looks like the global longitudinal strain have some advantages. Can you expand on that a little bit? We have seen in other diseases that indeed the global longitudinal strain apparently has a lot of potential for being a good diagnostic, but even prognostic marker. And some work from Heidelberg is actually on that in cardiomyopathies. So do you see, where do you see the role of longitudinal versus circumferential strain? So longitudinal affects more the subendocardial layer, therefore maybe more susceptible to ischemic injury. But do you have any other thoughts?
Yes, so I think longitudinal strain identifies myocarditis a bit better than the circumferential strain, and that might have played a role because some of the patients who had an underlying cardiac disease did have myocarditis. So maybe to differentiate this from the obstructive coronary artery disease patients, that might be helpful for to use the global longitudinal strain. However, for identifying the myocardial injury in total, both were relatively similar when you look. So the area under the curves was relatively similar for both of them.
Okay.
Yeah,
Okay.
so I think.
Yeah. Okay. So then last quick question. You need a separate sequence for that, right? That has to run on the scanner.
Mm-hmm. Yes.
Is that so? Okay. But the acquisition that you showed is a very, let's say, an impressively short protocol in general. So it was basically 15 minutes that you had to spend in the scanner at all without any intervention. So that's why I think this really is a very interesting option. Okay, thank you very much, Deborah. If you could unshare your screen, and then I would ask Marco Ochs, also with the University of Heidelberg, but now actually working in Mannheim, which is just a brief train ride away. Marco has been very productive recently with a lot of interesting and important research. And I would ask Marco now to come forward and present his study recently published in JACC imaging or JACC cardiovascular imaging and called hyperventilation breath hold maneuver to detect myocardial ischemia by strain encoded CMR. So we stay basically on the topic, but expand it to another aspect. And Marco, take it from here. Thank you for coming.
Yeah, thank you, Matthias, for the invitation. It's always a pleasure to be here. Another topic concerning strain and detecting coronary artery disease. We all are aware of the standard to detect obstructive coronary artery disease in CMR. That's a classical protocol used in CMR based on adenosine, which induces a coronary vasodilation, and based on a coronary steal effect, it induces in areas with an obstructive coronary perfusion territory a hypoperfusion, which can be imaged using a contrast agent bolus. And a typical protocol needs about 20 minutes. If you add late gadolinium enhancement images, we end up with 30 or 40 minutes. So we do know that it's still a time-consuming protocol, and so we came up with the idea: what could we improve in this standard of care? And one idea was to improve the speed. We wanted to get under 15 minutes because we think that's a very important, a critical point, which still prohibits that CMR is applied in many places. Here in Germany, we do have the advantage that many centers already use it, but especially in the US, nuclear medicine is still very strong. And I think that's a critical factor which could widen the use of CMR. We do know that CMR is very accurate in detecting coronary artery disease, but we still can improve. And we also know that adenosine is safe, but still has some limitations, contraindications for example, patients with asthma, with bronchial obstructions. Those patients are not the ideal candidates for adenosine, and also administration of contrast agents has some disadvantages. They are known to can stay in the brain for over a long time, and we don't know what happens over that period of time. So we try to target these points with a novel approach, with a needle-free approach of CMR stress testing, and this is a schema how stress testing with adenosine works based on the coronary steal effect. I mentioned it before. It uses a coronary vasodilation, and based on that, it comes to a coronary steal effect, where the coronary blood flow is redirected towards the healthy myocardium and away from the obstructed perfusion territory. And we had previous data from Matthias' group. Katie Fisher was very active with breathing maneuvers, and also Dominic Günsch. And here, as example, is a study from Rowan Damakuma in using nuclear imaging, and he showed that CO2, the blood levels of CO2 had a significant effect on the myocardial blood flow, and which was similar to adenosine. And we do know from in vitro experiments that the coronaries are sensitive, chemosensitive to CO2, which is comparable to the mechanisms in the brain. This was previous data from Katie, and she has shown that hyperventilation breath hold maneuver is more effective than a long breath hold alone on the induction of a coronary hyperperfusion. So our idea was to use that physiological mechanism of hyperventilation breath hold maneuver to get rid of the adenosine that is used. And our idea was to get rid of the contrast agent by using strain imaging. And it had to be a kind of strain imaging that is also that you can detect on a segmental base, and therefore we thought that F-Senk fast strain encoded imaging was the right sequence to go with. And this was our approach, and we set up a prospective study, which we recently had published in Czech Cardiovascular Imaging. And we have finally enrolled patients, all comers, a total of 122 patients that were referred to our center for stress testing. And we added to our standard CMR adenosine protocol an extra with a block with hyperventilation breath hold maneuver and an F-Senk detection. And the patients we have included here are the typical CAD patients, predominantly male, 66-year-old, and with a predominantly normal left ventricular function. This was the protocol. We started with typical CMR adenosine stress protocol, and we added these block. The hyperventilation phase had a duration of 60 seconds, and the breath hold we added was 10 seconds. So, our reference standard, where we compared our diagnostic accuracy to, was primarily the invasive coronary angiography. The data shows that the sensitivity of our approach was pretty high, pretty reasonably high. We had a sensitivity of the classic perfusion scan of 67%, so pretty low compared to the previous data, and a specificity of 92%. Our adenosine strain was by 82 and 83%, and the hyperventilation breath hold maneuver and detection by F-sync and strain was 81 and 86, and this was a significant difference to the classical perfusion protocol. So the data suggests that it might be a protocol with that is useful in the clinical practice. And another question we wanted to look for was the ischemic response. What happens in ischemic segments and in non-ischemic segments? And we have seen that both in adenosine and in hyperventilation breath hold maneuver, it basically happens the same. Ischemic segments, they get worse regarding the strain, so they show a functional impairment during the maneuver or adenosine perfusion. And healthy segments or non-obstructive segments, they improve in strain. And just to see what time benefit you can generate by that protocol, the hyperventilation breath hold maneuver was about 60 seconds, and the classic perfusion scan had 180. So a significant difference, of course, in the very relevant shortening of time. This was an example of a patient with coronary multivessel disease. He had a significant obstruction of the LAD, of mid-LAD. LCX was okay, but the RCA also had here in the proximal segment a high-grade stenosis, and he had no myocardial damage, no LGE shown in the scan. And what we did was a perfusion scan, and the perfusion scan showed obviously here perfusion deficit in the RCA territory, but we didn't detect the perfusion deficit here in the LAD territory. And when we look here at the strain, we already have seen at the baseline, at the rest strain acquisitions, that there was an impairment which increased under adenosine and hyperventilation breath hold maneuver. And here in the RCA territory, we see that adenosine and hyperventilation breath hold induced this regional functional impairment. So this was very suggestive for a obstructive coronary artery disease. Another approach we are currently evaluating is the dynamic hand grip maneuver. Just a few words about that. It goes in the same direction. We want to get free of any pharmacological drugs, and this is the approach where we use a hand grips in both hands over 2 minutes. And we've seen also very impressive effects, hemodynamic effects that are similar to dobutamine intermediate stress levels. And we are currently evaluating against the reference standard of coronary angiography. This is maybe the future, hopefully the future, where we want to get rid of pharmacological stress testing, our idea is to use pharmacological stress testing only in patients where there is a contraindications or that are not, don't fit for dynamic hand grip maneuver, hyperventilation, breath hold maneuver. So a backup strategy, and it depends on the patient which stress test to use, but our idea is that this needle-free stress test approach needs further evaluation, and we are excited what data the future will bring. Yeah, thank you.
Thank you very much, Marco. Great presentation, and I think also very clear. First of all, I find it very interesting, to say the least, that now we talk about seconds that we save. I remember the time where we said, okay, if we could shave off 10 minutes, that would be awesome. But now we're already talking between the two approaches here and the seconds. So I think we're clearly on the way to faster imaging and to safer imaging. And I think the point you made at the end is very helpful. If you could replace perfusion imaging by oxygenation sensitive and dobutamine by hand grip, then you not only get contrast free, but you also are able to address the two principal ways of quote unquote stressing. One is resembling physical stress, and another one is microvascular function or vascular function. And they may indeed play a different role. And typically we know that the physical exercise test, and that would be the hand grip, is more specific, maybe less sensitive, but more specific, whereas the hyperventilation hopefully can cover the sensitive part. And I think even a combination in some cases would help for this decision making. So the quick questions I have, because we're already a little bit over the time. One is, what are your simple words on, because of course everybody would talk about safety. Okay, you're doing all these maneuvers, and is that safe? Did you have any side effects, anything that was concerning in any of the patients? And also you were involved in the study with Deborah. Of course, in acute patients it happens even more. Can you comment on that?
Well, we didn't have any serious side effects. I just remember one patient, and this patient did both. She did a hand grip maneuver and hyperventilated. And this led to severe nausea, and she ended up in the neurology department, but everything was fine. Okay. It was just a heavy stress.
Okay, yeah. Yeah, okay. And then a question from the audience. Can you talk about absolute strain differences and how that would affect clinical differentials? So the absolute difference, is that in an individual case enough to inform a clinical decision?
Yeah, the point is that initially when we started the evaluation, we had the idea that we can rely on individual values, but we realized that it's not possible, because the software gives you an average over a total segment. And this is way not sensitive enough. Mm-hmm. What we then did was a visual assessment of these strain maps. Mm-hmm. And these strain maps allow to detect by a visual analysis subendocardial defects. And these mm-hmm. subendocardial defects, they are very sensitive for this kind, for mm-hmm. obstructive coronary artery mm-hmm. disease. Mm-hmm. And we are currently developing with MyoStrain together an approach how to get these visual effects into a quantifiable number. Yeah. And to answer the question, currently we cannot say what is the cutoff in total numbers. It was based on a visual assessment. So if we have seen in the color map we have an impairment, that was straightforward, and we had the suspicion for an obstructive coronary artery disease.
Okay, and last question for those people who want to get into that. What are the most important obstacles? Is there a learning curve? What would people have to really especially take care of to make sure that they get to good results when they want to use that tool?
Definitely, there's a learning curve, and I made the same experience when we started with the project. I think it's the same when you think back, when you evaluated the first perfusion imaging. There is a learning curve you have to get used to, or what you can expect from a coronary artery disease. But as you get into gathering experience, it gets very fast easier, and definitely you should get some instructions. What are the key points to look at?
And the acquisition of the images, so the planning and such, is that straightforward?
Yeah, also the planning is critical. It's a technique where it's very important to have the right alignment with the myocardial walls. So this indeed is a point where you really have to train your technicians. And in Heidelberg and here also in Mannheim, our technicians are now very experienced, and it doesn't need any, in most cases, no corrections anymore. But at the beginning, we made it together, the acquisitions and the planning with the techs, and this is time intense, and takes some time.
Okay, effort. So in summary, it is something that requires an experienced center, and then probably is where perfusion imaging was, as you said a while ago, when we had just a visual analysis and you needed some experience to interpret that. But with perfusion imaging, we are now at a stage where we can do this quantitatively and even automatically. So these tools become available. So hopefully that will also apply in the future for the strain approach. Well, Marco, thank you a lot. There is one more question. I feel bad for those who have to, you counted on our punctuality. Do you think strain rates could add sensitivity to the detection of myocardial ischemia? So strain rates instead of just looking at strain?
I cannot answer that. Maybe, yeah.
Okay. That's something to explore.
We don't have the data, could be,
although the temporal resolution for strain rate, the requirements are even stronger than for just strain. So but it's certainly, again, a good question and an interesting avenue. So thank you very much. I will, before we let you go, I wanted to show, I don't know whether you can see my screen. The next level or the next journal club will be on July 7, the CMR Journal Club, and we will present these papers. Bettina Bessler will do that on the prognostic value of stress CMR in asymptomatic patients with non-coronary artery disease. And also a very interesting paper from London, the influence of the arterial input sampling location on the diagnostic accuracy of CMR, stress myocardial perfusion quantification. So it is, again, about stress CMR. And I also want to briefly point out, next week is the next JCMR Journal Club, and will be presented then by Scott Flam, and it will be about an article titled Comparing CMR strain software packages by their abilities to discriminate outcomes in patients with heart failure with preserved ejection fraction. So strain is a kind of an important topic apparently here in the June editions of the journal clubs. So with that said, I want to thank everybody for coming, especially Deborah and Marco for fantastic presentations. And I wish everybody a good day or good evening wherever you are, and stay safe and enthusiastic about CMR. Take care. Bye-bye.